Hello, my name's Simon Rinne. I'm a social worker and also the founder of Mindful Men, which is a therapy business dedicated to men's mental health and disability. And I come at that with lived experience of mental health challenges myself. So for over 3 decades, I've lived with obsessive compulsive disorder, experienced depression, anxiety, burnout, and used alcohol for many, many years to numb the pain and feel normal. And actually, as we're recording this, in about 1 month's time, I'm 12 months sober. So that's a huge thing for me.
Hello, I'm John Cuturillo, the life coach of your listener and the host of the podcast of the same name. As a coach, I combine evidence-based strategies with a wealth of personal and professional experience to comprehensively help people to learn about their minds and to make the changes that they desire in life. In doing so, I work to combine the best aspects of traditional therapy and contemporary helping professions while addressing the limitations of both. And on my program, I discuss social science and critical thinking. Welcome to this collaboration between the Mindful Men podcast and the Your Listener podcast. Today, Simon and I will be discussing the topic of our experiences with mental health services, both in our professional lives and our personal lives. We'll be discussing some aspects of the mental health paradigm and the various practices that we believe need updating, and also what we find particularly helpful. Now, before we begin, we should advise you that nothing you see on the internet should be taken as advice. So if you have concerns about any aspect of your life, whether it be your mental health or otherwise, we advise you to seek the help of a professional, whether it be a social worker, a life coach, a psychologist, or otherwise. And additionally, we're not suggesting what you should or shouldn't believe about the issues we discuss or denigrating particular views. What we're doing here is presenting perspectives so that we can prompt conversation and instigate critical thinking. You can use your discretion when using them, but use this for informational purposes. Simon, both you and I have some significant experience with the mental health industry. We're both either are or have been professionals in this particular space, me having been a former paraprofessional social worker and therapist, you being a registered social worker and therapist, and both of us having used mental health services throughout our lives. I imagine that there's not only a lot that we found helpful, but that a lot that we believe needs to change, and we're actively partaking in changing.
Yeah, absolutely. It's been a journey for me over 3 decades, as I mentioned earlier in the introduction, and now fortunate to be in a space where I can use my lived experience to support men in their journeys as well, now as a social worker and therapist. So lots happened in that time that I've learned from, in terms of what's good, what's bad, what's ugly, and I use those experiences to really tailor my supports in a way that guys can relate to as well, which is such a passion for me, and it's so good to be here. Even talking about it is so good, because for many years I never spoke, like most guys do as well. So this is just part of the process, isn't it? Having these discussions, exploring these topics, and drawing from those lived and learned experiences as well to try and make the world a better place.
Absolutely. And Simon, I have to say, in the time that I've listened to your experiences, your ethic when it comes to the client-centeredness of your care that you provide is quite evident. I'd like to think that for the most part, people who do enter the professions that we enter do have the same ethic, and they are able to achieve excellent results in the process. Unfortunately, though, I think in both of our professional lives and our personal lives, we have also seen some unhelpful aspects, not just in terms of individual people's actions, but also perhaps of the mental health paradigm. Professionals may follow them with the best of intentions, thinking that they're going to be helpful, but on the client's end, it doesn't always come across that way, does it?
No, not at all. And I think that's where the lived experience can really thrive. As therapists, we can really draw on our experiences, whether they're good, bad, or ugly, and tailor our services accordingly. Like I've over my journey, I've seen psychologists, psychiatrists, social workers, counselors. I've seen coaches, mentors, all of the above, and had some really good experiences, but also a lot of poor experiences. And I attribute those poor ones not to the person's capabilities as a therapist, but I think it's more the disconnect of that lived and learned experiences. The ones where I've had amazing experiences have been where with therapists who have shared a little bit of themselves in therapy. And that's when, when they're talking the same language that you're talking, it just goes a long way to making you feel comfortable as a client of the system, whether that's mental health, whether that's disability. It just goes so much further than if you've got someone on the other side of the room or the phone or the Zoom call or whatever it is who just has the book smarts, not so much the street smart. So it's something that I'm constantly evolving as well in my practice, and how do I best deliver services, and very mindful that it's not about me. Even though I'm bringing lived experience to it, I'm very mindful that this is all about the client that I work with, the person on the other side of the room or the phone call or in the car or whatever I do in terms of the delivery. It's very much about them, and how can we tailor each session to that particular person's needs. And that's really important as well, because it's not like you can just apply the same theoretical concepts or provide the same interventions for every single client, because every single client's different. Every single client's going to respond in a different way. So it's constant mindfulness in how we deliver our therapeutic services.
Indeed, Simon, and the metaphor of language that you use, speaking the same language, is the perfect one, because even a therapist who does communicate relevant therapeutic ideas to their client will be less effective if the means by which they're communicating, in terms of the language, the sentiments, and the frame of reference, and potentially the communication techniques like metaphors that they use, aren't enough to engage the client's cognitive mechanisms that allow them to feel understood and allow them to understand themselves more deeply, that's going to facilitate the healing. And it's perfectly possible that a lot of therapists do have lived experience, but part of the paradigm may be to disconnect your lived experience from your professional life. And that, from what you're telling me, is it's counterintuitive and in the long term counterproductive.
Absolutely, because mental health is a human experience. And so if we don't put ourselves in it as humans, how can we support other humans to evolve and to develop as well? And I remember university and often being told it's not about you, it's about the client, which is absolutely true. And so often being told don't share your experiences, it's not about you. And so coming out and speaking to a lot of other therapists in various fields, whether it's, in the therapy space, like what we're in, the counseling and coaching space, or even if it's like physio or speech therapists or occupational therapists, there's a very big tension with everybody that I speak to about how much do you divulge. They want to divulge because it can potentially help a situation, but they're fearful because of what they've learned at university or in school or at college or wherever they've done their training. And it's reinforced again in their associations where they register as well. And so I take that with a grain of salt and say, well, if it's purposeful disclosure, that can go a long way. I had a great experience a couple of years ago, I think it was 2020, where I burnt out. And my GP and my social worker that I saw both disclosed their experience of burnout, which just helped so much for me to go through that process of to talk about what was going on in a way that was going to be non-judgmental and non-stigmatizing, and then actually get the right help that I needed, as opposed to going to someone who wasn't going to disclose that and just give me tools and feel that disconnect that I have so often felt before. And so there's a bit of a tension there, and it comes from what we study and the associations that we're a part of. But I think once you start doing it, it's so freeing as a therapist. So I was having this chat with a social worker a couple of weeks ago who had this same tension. And she was like, oh, I want to be a lived experience therapist, but I'm scared to be. I'm like, well, the way I approach it is I introduce myself as a lived experience therapist. So when someone comes to see me or I'm doing another professional networking thing, they know straight off the bat that I'm a lived experience therapist and I'm going to talk about lived experience. So there's no, question about when I bring it up, because it's going to come. And so I set the scenes from day one.
Absolutely. Your innovations definitely, as you say, bring the humanity into the therapy space. And let's discuss some of the specific issues that we have found. One of the issues that I found particularly detrimental to a therapeutic experience is over-pathologizing. In other words, interpreting every aspect of a client's functioning, whether it is objectively normal or not, or objectively healthy or not, as constituting a part of their pathology. A couple of examples that I've experienced personally, I'd be glad and I'd be interested to hear your own thoughts and perspectives on your own experiences. I was once seen by a psychologist and I stopped being able to attend her clinic in person because I lived too far from it, and I was working at a rate that I had to attend the office regularly, and I couldn't take time out of my day to go visit her, but I could see her via video conference. I explained to her what the issue was and that I was happy to keep seeing her via video conference and was even happy to take whatever risk was involved in that, but I just couldn't take the time out of my workday to go see her. She said to me, "I'm wondering whether you're trying to make excuses for yourself not to recover," or something to that, or something to that effect. Another issue that I've particularly found, which is not something I found as much personally, but it's general in treating various symptoms of psychopathology, including, I believe, anxiety and depression tend to be some of the most common phenomena in which this tends to be relevant, is when a person is mistrustful, it's always linked to the person's pathology. So if a person doesn't trust the world, they don't trust a particular person, if perhaps they're dating and they're distrustful of the people they're dating, the psychologist will always link that back to whatever phenomenon they're experiencing, anxiety, depression, or otherwise. And I can't cite specific examples, but I intuit that there's a lack of discernment in practice in which people don't carefully analyze that and discern what is normal mistrust or healthy mistrust, for example, having healthy boundaries, from being overly mistrustful.
That screamed out to me a medical model of mental health, right? So the medical model, very broadly, trying to cure disease, essentially. Health is the absence of disease. And so, but what you're describing for me is you have to work. You're willing to do the Zoom call or the online thing, right? You've got a life outside of your mental health. So this is the social aspect of you. So when we're doing like a biopsychosocial assessment, it's not just the biology, what's happening biologically for you, and we're going to give this a label and we're going to try and cure that, but it's excluding the social. You've got to work. And it's 2024, and I'm not sure when this happened, but we've had this thing called technology for a while. And so you're able to actually access the right supports for you, even if you're not in the same physical location. Now we can do this worldwide. And I think that is in itself is the way that we look at mental health is a big challenge. It's something that we try to cure, and we expect someone to go to a session, get the help, get a medication, and they're cured. And that's it. We'll never see them again. But the reality is that mental health is quite a social condition because it's influenced by our environments, it's influenced by our history. And this, I guess, comes into the next aspect of what you were describing there is the mistrust, for example. So a lot of the time, mistrust is developed by our pasts, our histories, our current environments, and the people that are around that. It's the media that we consume. It's the thoughts and the beliefs and the values that we have. And so what we actually have to do as therapists is explore all of that. And so what I quite often do is, rather than looking at the label and going, okay, well, this is what a book tells me about this label, my first question, whenever they say they're experiencing something, whether it's mistrust, whether it's, I can't get there, can we do a Zoom or a phone call, is I ask them what they mean by all this. What are their definitions of this? What does it mean when you say you mistrust someone? What does that mean to you? Because your meaning for that is going to be different to my next client, because we all learn and perceive the world in very different ways. And so it's my role, particularly as a practitioner or therapist or social worker or bloke, whatever you want to call me. And this is what I say to the guys as well. When you come in to see me, you're not necessarily seeing me as your practitioner or your therapist. You're seeing me as Simon. And you can call me whatever else you want. Doesn't matter what my title is. It's to explore those meanings, and then the meanings behind the meanings, and then the drivers as well. Because once we do that, we get onto the recovery pathway. So you not being in the same room doesn't negate the fact that you want to recover. You're still showing up. You're just showing up in a different way. And that's very important, because in the modern world, many people can't physically come out of their home to go to therapy, or they're stuck away at work, fly in, fly out guys, workers, or, the ones that are on oil rigs. How are they going to get to a psychologist's clinic or a counselor's clinic, And so there's that aspect. And then the other aspect, I guess, is how we fund these systems. And we have the Medicare model here in Australia, and it's very restrictive in terms of where you can do therapy, how you do therapy, etc., compared to the NDIS, or the National Disability Insurance Scheme, where it enables practitioners like me to go out into community and do sessions in community or in someone's home and do it quite freely. And so we have these I guess this adds to the paradigms of to where the funding's coming from and what that practitioner is thinking about when they're seeing someone. Are they seeing someone because they need to tick a box for a mental health care plan? Or are they seeing someone because they've got a long history of alcohol and drugs and they need to rehab? Or are they seeing someone because they're a lived experience therapist who gets it and knows that you just showing up, however that looks, is really important? And so we have these different frameworks that we come from, these different experiences, these different modalities. We have these purists who just do cognitive behavioral therapy and they stick to it no matter what. I like to go between a whole bunch of things because, as I said before, not everything works for the same people. The first ever therapeutic intervention I was given was a thought diary from CBT. I hated it. I didn't want to do homework. But when I started doing acceptance and commitment therapy and learning about values, I'm like, this is what I need to understand me and then understand what works for me. I don't need to sit there and dissect my thoughts. My thoughts are in there 24/7. I've got OCD. But what I can do is tune into my values and go, okay, what can I do today that's values led? Being human in a space allows someone to first disclose information that they've probably been holding on for a long time. For example, it took me 20 years to go see my first therapist. 20 years of me struggling in silence. So it might be the first time that they've seen this person. And then you've got to build that therapeutic rapport so that they keep sharing and they keep rocking up. And then you might get to a point at some stage, and it's not necessarily in 6 sessions, where they actually go, okay, this is the real issue. And then you start doing the work and then you start doing the magic. And a lot of that is just holding space. It's that humanity side.
Indeed, the illness is characterized or conceptualized on a very shallow level. It's trying to make the job quick when there isn't really a quick solution to these problems that people experience. And it also brings to bear the reminder that our environment places a lot of demands on us as practitioners. So anyone who works under the NDIS, for example, which I have, a lot of what I had to do was compliance-based work. And a lot of my clients, I could feel my clients' frustration in sometimes the time that it took for me to complete tasks and some of the questions that I had to ask them. But one of the ways I would introduce humanity into it, which I'm sure you've done as well, is to say, I know this is probably frustrating for you, but unfortunately, it's a demand that we have to meet in order to remain compliant. So I would try and make the processes as efficient as possible for them without compromising the quality, and then move as quickly as I could to the meaningful work.
And there's a lot of this discourse I see in social media and in community circles. Oh no, you get free mental health. I'm like, it's never been free. It's just that you have different practitioners who do different rebates. But largely it's subsidized. It's heavily subsidized. You get your 10 sessions now this year. 10 sessions. But I can go to the physio as many times as I want, for example, if I've hurt my leg. We've still got a long way to go to accept that mental health is actually a really big issue. And if we're mentally well, we're going to be at work longer, we're going to study better, we're going to have better relationships, we're going to be better people. We just keep our physical health going because we've got to be the workers, right? That's that traditional society model of capitalism. Make money, pay your taxes, the money cycle keeps going around and round and round. But when we want to spend money on ourselves, if we look at it less as a financial burden and more as a financial investment, we can go a long way. We're just about changing our mindset and how we look at it and how we conceptualize it, how we talk about it as well. Who are the leaders in this space? Who are the people that are actually making genuine change? And unfortunately, there's not many. It's left to the non-profits. It's left to the crusaders like you and me, the advocates, to do it from the grassroots up. It's not coming from the top because the top is all about news bites that you can get on the news for 5 or 10 minutes and just keep yourself relevant in the media.
If the NDIS is not sustainable, there are multiple reasons I can posit from actually seeing them firsthand. Number one, the inefficiency of how the funding is assigned. Often we try to conceptualize people's disabilities from all these different angles rather than understanding them in one holistic way. And by trying to fund all the different types of services that look at them from all different angles, we're duplicating a lot of work that's been done. Whereas if we were to understand the metaphysical nature of what somebody is experiencing and implement perhaps a smaller team that is only separate where they need to be, but at the same time is a specialist in their area where they have a deep understanding of how to address that person's problem in a way that's going to collectively be holistic, it saves money compared to hiring a larger number of practitioners that are disconnected from each other and don't conceptualize themselves as being part of a common goal to help that person live life optimally. They're only focusing on a small area. We have to be willing to properly understand each individual person's needs and experience and address them holistically through a collaborative and focused effort. Focused being the key word here, because we have to be able to conceptualize. I have to do something that complements what all these other practitioners are doing, because only by working together is that person going to truly be helped.
I worked in the NDIS and now I'm outside as a practitioner. So I was the person who used to press approve on NDIS funding. I was a planner. The idea and the premise behind the NDIS is that it is a holistic thing. It's about looking at the person as a whole, not just their disability, their choice, their control about how they use their funding. And it's not just about the participant, it's about the supports around them. It's about the mums, the dads. It's about making them family again and not support workers, because that's what happened in the old model. So it's meant to be a system that is about the whole person, but it is really about the disability. And so as a planner, you struggle with that. And particularly me as a social worker, someone with a social work framework, and I was studying social work at the time, and I'm getting all these ideas about what it means to have a social model of support as opposed to a medical model as well. So that was influencing my thoughts. But then on the outside, as a participant, you have what's called psychosocial disability. And often their plans would be heavily, scrutinized, reduced, because you can't see the disability. There's disadvantage within the system that is meant to remove disadvantage, especially what happened with the mental health space and the psychosocial disability was, oh, you have a psychosocial disability. This is more Medicare. This is more the mental health system. It's this handball between different financial bodies, but both of them don't want to blow out in costs. So the handballing between, and then this is where you get the stalemates. This is where you get the people stuck in hospitals, because two systems don't want to talk to each other. And now there's talk about removing psychosocial disability from the NDIS. That talk's been around for many, many years, and it just keeps coming up. Whether or not it will happen, I don't know. And there's this uncertainty that's constantly arising because of politics. And so now they're even talking about the NDIS is for profound disability. But what about the people that don't have profound disability? Like, where do they go? And it's really disappointing, because this is a program or a body of funding. Why not merge both of them? It's not hard. We just got to actually bring everyone to the table, talk about it, create a framework that actually works for everybody and not just for some. Often a lot is said in politics in the lead up to elections, but then nothing really changes on the back end.
You've made a lot of excellent points, and they are all relevant to another issue that we've both discussed as really needing to change in the mental health paradigm, and it's that of reification. I'll explain it briefly to our audience. I actually made an episode on this some time ago about the issue of reification, and I'll give some examples as to how it operates and then how we can combat it. Whenever you try to work with something that is invisible or not concrete, like a thought, a feeling, a mental illness, then you have to have some type of concept and set of to structure the way you think about it and the way that you work with it. Now, the problem with a lot of psychotherapy practice and mental health practice is that it tends to use limited conceptualizations of what an illness actually is, and the disconnect between the different practices that work both inside and outside of the NDIS, and also the fact that we separate the NDIS and its paradigms from the medical system, or Medicare and its paradigms, are another sign of this. Reification essentially posits that just because you think about something a certain way, that it must be that way in objective reality, that your perception of it is the truth about it. And the problem with this is whenever you use a limited framework to conceptualize something this complex, then you end up missing parts of it. Now, I'll give an example from my personal life and the personal lives of other people. So I have borderline personality disorder. That's one of my diagnoses. Now, my case is particularly mild. What that means for me personally is that emotions arise inside of me that, when they heighten to a certain extent, limit my capacity to think, to retrieve information from memory, and to use information to make decisions. That has arisen from past experiences and from faulty beliefs that I was taught. It's better now. I'm towards the middle to the end of my recovery journey. But when those thoughts arise at an unconscious level, they influence that experience. And the recovery journey for me has been about understanding what's happening inside me, why those experiences happen, and then how I can combat them in a way that's not destructive, that's constructive. I have known people who have had severe enough presentations of borderline personality disorder, or BPD as we call it, to be on the NDIS. Now, the social model of disability conceptualizes this as psychosocial disability, and they conceptualize a recovery model. So in that paradigm, the diagnosis isn't relevant. What's relevant is that I'm not necessarily objectively unwell. It's just that my interactions with society and society's perception of me are that I'm unwell, and that I must go on a recovery journey, which is not about cure, it's about living the best life that I can. Unfortunately, I've tried to look up definitions of these concepts in this paradigm, and unfortunately no one defines them properly, even the people who claim to advocate for it. So this is one of the problems. But according to the people who advocate this paradigm, the medical model is you have something wrong with you and you need to be cured. The problem is that the manifestations of either of these are completely inaccurate on their own. The medical model would posit that I need to be cured, and the way they do that is through traditional and rigid therapeutic modalities. If you take that too literally, basically what it conceptualizes my illness as is a series of inaccurate thoughts that I'm acting on too quickly, and what I need to do is slow down and think more rationally. Okay,
Yeah.
technically that is true, but when you implement it literally, it would do nothing to help me. A practitioner who takes that literally will completely disregard my history, will completely disregard the internal experience, will only take a description the best they can and say, right, this sounds like an irrational thought. Substitute it for a rational thought. For example, if you get triggered because someone said something to offend you, substitute it for, I don't think they meant to offend me. Again, that could be objectively true, but the delivery is completely ineffective. The social model posits the minute we mention diagnosis, it's stigmatizing. The minute we mention treatment, it's manipulative. The minute we call it an illness, it could be considered us denigrating you because we're saying there's something wrong with you as a person and you have less moral value. Here is what I would call a correct conceptualization. Okay, I have an illness. We use the label as an illness because we need to identify that there is something wrong that I would like to correct in my life. Because if you have a mental illness out there, you will know it can be a horrible experience and you want to feel better within yourself. You want to live the best life you can. It's not your fault though. And saying that you have an illness is not saying it's your fault. It's saying you clearly have something wrong in your life that you would like to change. And it's okay to want to change that. Doesn't mean it's your fault. Okay, so I have an illness. We've identified what it is. And the reason diagnosis exists is that it allows us to accumulate all the knowledge we've learned about what can happen to a person and then put it into a concise framework so that when someone describes it, we can identify what it most likely is based on what we know and what's most likely to help. The first thing we need to understand is what is it actually, as you said, Simon, this is something you said that I don't hear a lot in mental health. What does it mean to you? Like when you get triggered, what does your body feel like? Does your heart rate increase? Does your breathing become more rapid? Do you start to sweat? Does your head start to ache? What are your thoughts? Some of the thoughts that people with my condition might experience might be, oh no, I've said something wrong. I'd better take it back so no one judges me. Oh no, I think this person's judging me. If they abandon me, I'll be alone. Are those the thoughts you're having? How does it feel? Do you feel lonely, rejected, depressed, angry? What do you feel like doing? Do you feel like breaking something? Do you feel like crying? Do you feel like crawling into bed and never getting out ever again? And then let's examine it carefully. When this happens, in the heat of that moment, what are some things we can do that's going to help you feel better, that's going to help you take back the power so that you are the master of your emotions as much as possible. The emotions aren't the master of you. Might it mean saying to someone, I'm not feeling well at the moment, would it be okay if I took a minute's break? Could it mean saying to someone, I'm not sure what you meant by that, but I'd like to make sure that I don't accidentally mischaracterize you. Could you please clarify what you meant? Because I felt uncomfortable at that comment and I don't want to misattribute what you've said. Could it mean saying to someone, I know I'm feeling a bit horrible at the moment and I'm not sure why, but would it be okay if I spoke about it with you? Or if someone is not being reasonable, being able to be assertive and saying, this is making me feel horrible right now and I think it's fair that we talk about it in a more equal fashion where you're not trying to manipulate me. That is a holistic understanding cause, experience, and then how you directly address the experience. That's a holistic way of doing it. And in reality, one practitioner, when they're learned enough and experienced enough, could do that. And then might advise people who are on the ground, like members of your informal support network, your own family and friends, or your support worker. And to speak to the NDIS model, That's how you make it more efficient, by not disconnecting services, by having a central body of knowledge from which every person draws.
It's an interesting take on it. I'm actually glad that you framed it like, what does recovery mean? I look at recovery and the mental health journey, disability journey, whatever journey it is. Doesn't matter, even have to be related to what we're talking about. Your career, your family's life, your social history. It's like a roller coaster. There's days when you're up, there's days when you're down, there's days where you're twirling around and you're having the best time in your life. There's days where you feel like you're about to face plant into concrete at 1,000,000 miles an hour. You've got vomit all over you. It's just not your best day. But then it comes back up again. And it's never the same. And one person's roller coaster could be very short, could be a week, or one could be 30 years. There's a couple of issues that I'm finding we're coming up with in these models is like we can't put a label on it because it's degrading. I can't talk for everybody. I can only talk from my experience. The best thing that I ever did was get a label, because once I named it, I could then tame it. And this is to quote Jamie Usher, a good friend of mine, name it to tame it. So once I knew I had OCD, depression, anxiety, I knew the feelings. I could attribute them to something. All of a sudden, 20 years made sense. The challenge then, and I think you touched on it, is the practitioner's capabilities to explore those experiences. What does it mean to you to feel depressed or anxious? The challenge I had was OCD. So diagnosed with OCD 2012, I saw many, many, many therapists over the next decade, and they all wanted to target depression and my alcohol use. I didn't understand the alcohol use, why they were targeting how much I drank. That didn't make sense to me. Does now. But depression, I'm like, oh, okay, I don't really want to talk about depression. But anyway, let's talk about depression. Let's talk about alcohol. Let's talk about the stress that I'm under. And it's around the practitioners wanting to focus on CBT, cognitive behavioral thought. What we talked about with the thought diary. You've got an irrational thought. So OCD is irrational thinking that is amplified because we can't get rid of the thought, and then reinforced because we do a behavior, whatever that behavior is. For me, it's checking things, checking the doors. A CBT model will just go, you just exchange the thought, just reframe the thought. No, it's about, in OCD, it's about actually preventing the response, preventing the behavior. And when I found an OCD therapist who could explain that to me, it enabled me to start recovering from OCD. And I'm like, okay, now I've got the label and I've got the book, the guidebook, which is exposure response prevention. It's not CBT, it's ERP. Now, ERP, or exposure response prevention, is part of the cognitive behavioral therapy framework, but it's not so much focused on your cognitions and your cognitive thoughts. It's about the behaviors, because that's what keeps it going. That's the fuel for it. I practice between cognitive behavioral therapy, acceptance and commitment therapy, motivational interviewing, solution-focused brief therapy. They're the ones that I go to, and I draw different tools from all of them. But a lot of that is underpinned by just holding space and having a conversation. It's just about, who are you as a human? What is your human experience? What is our shared human experience? That's where the lived experience stuff comes in. And how can we share supports with each other so that we can feel like we're less alone in the world, that somebody else out there gets it, and we can try different things maybe, and have that encouragement, have that accountability as well. If we look at the medical model, so the Medicare model of mental health care plans, it's 6 sessions, then you've got to go back and get an extra 4 sessions. The Medicare model is designed for mild mental health challenges. You've got mild depression, you've got mild anxiety, and that's pretty much it. It's not really for entrenched, decades-long mental health struggles or intergenerational trauma, or it's not really designed for that, but that's what we use. And then you've got the NDIS, the disability space, where it's all about trying to build capacity and recover. They use the recovery framework in all the disability. The idea being that your first initial few plans might be higher, but as your capacity builds, your NDIS packages get lower and lower and lower, so that you can live life without supports, essentially, or with minimal supports, right? That's the concept around it. The challenge in that space is that as soon as you as a practitioner say, John experiences BPT or Simon experiences OCD, we're mentioning diagnoses, okay, which is okay for the NDIS. And the recommended support is these types of therapies, right? That's what the evidence tells us. As soon as you start doing that as a practitioner, an NDIS plan goes up. This is the medical model. You're not meant to be doing this. No funding for you. And then, so me as a planner or me as a practitioner now, it's like, well, what are they meant to do? How are they meant to build capacity if we can't use the tools that are at our disposal? We've got to change our language just to appease the people that are providing the funding. And so again, it comes back with all these systems coming together and getting shared language and really using lived experience language as well. NDIS was good at that. They're good at that in terms of having people with disability inform how it's structured, but they still have a lot of work to do. Mental health, Medicare model, it's done by medical practitioners with decades and decades and decades of experience, but I think that has lost, that doesn't have that lived experience model. And that's why you're seeing lived experience peak bodies starting to pop up saying, hang on, we need to actually embed lived experience speech in the way that we design and talk about these systems and processes.
Really, we shouldn't have to, as practitioners, evade reality to appease a system. The system should be acknowledging reality. So regardless of whether or not you as an NDIS, this person as an NDIS worker, or this person as a therapist is seeing this client who has BPD or OCD, the actual phenomenon they're experiencing isn't changing. And this is one of the frustrations that I experienced, in that the NDIS might say, oh, it's not treatment, that's bigoted, it's capacity building. But every time you help somebody properly, you are building their capacity to live an independent life, which is dignified. So a therapist, a qualified and competent therapist, is going to help you build your capacity. And I've also seen programs in the industry under the NDI, specific mental health practices, whereby they try to manualize the program. So they basically train entry-level practitioners in a particular framework and then say, okay, here's the manual, deliver this program. And even I was on the receiving end of these types of speeches, but you have these people who have been only fed information from a book, who are saying, John, we know you have a lot of clinical knowledge, but this is the social model. It's like, no, you've never had a mental illness, evidently. You've never understood that regardless of what we call it, the phenomenon is exactly the same. This trying to sugarcoat the reality of these people's lives with progressive language is not going to change what they need. They need someone who knows it, who has experienced it, and who understands it, and is going to be able to, as you say, speak the language and help them find things in a frame of reference that works for them.
I had this in one of my sessions many months ago, and the person living with disability, so the NDIS participant, said, Simon, have you ever experienced depression? I'm like, yeah, like let's go through that. And so gave a little bit of insight into my experience of depression, which helped him to conceptualize what depression was. And then, a few months later, we come back and we're talking about it again. And I remember him sharing something with me about how he got through depression. And I said, you know what, I did that thing that you did, and I found a lot of benefit. So it's a shared thing. I'm really proud to say that I employ now lived experience practitioners, which makes for a really dynamic company when you've got practitioners who can go to different levels, who can specialize in maybe different types of mental health challenges or disability. Like, even though I'm the senior clinician in the company, I'm going to be learning. So it becomes holistic, and even from the practitioner level as well, and from company and agency levels. It's not just about looking at the client or the participant as in a holistic way. It's about how do you look at the whole system in which this participant or client engages. I guess that's like systems theory, isn't it? It's like it's all interconnected, it's related, it's all influencing each other.
A good therapist learns as much from their clients as their clients learn from them. Relevant to that issue of the way that we sometimes look over people's experiences and disregard what a person is trying to communicate to us, there's another issue that I think really needs to be addressed, and that's dignity of risk, and which is acknowledging that even if somebody is ill in some way, that it doesn't inherently mean that they can't make decisions for themselves. It doesn't mean that a practitioner should have the power to have too much control in that relationship. One, because you're disregarding the person's rights to make decisions for themselves, and two, because even in some instances where the practitioner could potentially make rational decisions for that client, setting a precedent on what we call the slippery slope of allowing someone that much power is eventually going to lead to them potentially being able to exercise power in ways that they shouldn't. So we have to have boundaries and ensuring that we don't abuse our power. But a few instances that I've seen, which might seem a little bit comical in hindsight, is that same psychologist that I mentioned earlier whom I couldn't visit actually ended their therapeutic relationship with me because they believed that I wouldn't be willing to be as vulnerable with them and honest with them if I was communicating via video conference as I would if I was in clinic. I've heard other examples. For example, a psychologist instructing me to be vulnerable rather than clinical, because I naturally describe things using clinical language, and then trying to educate me in matters that I already demonstrated that I knew, which was a little bit awkward because I was trying to explain that I know this, I need to learn beyond it in order to get on the recovery journey. I've had a few psychologists, believe it or not, say, oh, we don't want to diagnose because diagnosis could add stigma or interfere with the treatment process. Therapists being too controlling of the process and trying to guide it in one direction rather than letting the client just speak their mind, and the therapist taking on the task of being able to help them work through each aspect of their story without losing the therapeutic connection. Compliance is a big issue in that same space as well, because sometimes there are so many compliance issues imposed on us by the paradigm that we're forced to waste so much of our time and so much of our therapeutic energy doing that instead of helping the client. Like I know in certain professional bodies codes, there are stipulations that if a client is contemplating suicide, and I'm not saying that this is inherently bad, but if a client says they're contemplating suicide, there's a threshold above which you're allowed to make a report to the medical system to protect them. You're allowed to break confidentiality, or you're allowed to break a therapeutic alliance if a client loses contact with you with a certain period of time, or is not. Some practitioners have even said, if you don't give emergency contact details, then we won't treat you. Again, suicide's bad. We know that it's bad. There's no doubt about that. But are we really respecting their dignity of risk if we basically say, right, here are my terms. I need to be able to trust you as much as you need to be able to trust me, and I'm able to control that decision that you make for yourself because it's my responsibility to protect you. Well, it's our responsibility not to do anything that harms our clients. But if we're administering therapy properly and the client still harms themselves, do we really deserve to have that much power? Like, is it safe?
It often comes up for therapists is who are you protecting, the client or yourself? And I think imposter syndrome comes into this. So I've had these conversations with my supervisor, and this is where supervision is critical, right? We talk about this, and it comes back to meanings as well. So someone says, I'm going to go kill myself today. What does that mean? Does that mean you are actually going to do that? Or does it mean you're just saying that because you're frustrated or you're angry and that's just your words? That's the only words you know how to express that. We say throwaway things all the time. And so it's being mindful of the meanings behind our words as well, but also how that impacts us. What is that triggering in us? If you need emergency contact details and you need people to sign on the dotted line and all this type of stuff before you even do therapy, is that because you're worried about all the legal ramifications as opposed to the client's well-being? So it's about looking at your systems and your structures and recognizing that you don't have to do it the same old way that everyone else has done it. So this is why I do therapy outside. There's only a small percentage of my clients that come into a clinic. There's a few clients that I see on telehealth because that just works for them. Some of them don't even do Zoom. They don't want to see me. So we do phone. But most of my clients, we go out and about in community. It's therapy with, not over. Some days it's risk assessments for suicide, and it's asking them, are we talking about actual suicide, or are you just expressing this using just this language? Asking them, what do they want to do? Do you want to go to hospital right now? Do you want to call 000? Do you want to call Lifeline? Do you want to call your emergency contact person? Many of which in the NDIS space, disability space, they don't have an emergency contact person. Or even the private clients I see, they don't have other people. They're alone. Or they don't want anybody else to know that they're seeing therapy, which is okay as well. That's self-agency. I don't make everyone sign a document. In fact, I'm trying to save the planet by not printing out forms. So we do things electronically, or I get verbal consent. And if I'm not sure if they can make that consent themselves, then I say, can I talk to your mum or your dad or your guardian or someone who you trust, so I can explain to them what's going on so that somebody else knows what's going on as well. So how do I bring in informed consent in a creative way as well? But it's also around design of sessions. Take it outside. Is it sitting with them? Is it going to grab a coffee? And normalizing just a discussion, because sometimes it's just them being there is what they need, and they take it wherever they take it. I often come, or actually every session I come with some idea about what we could do. The key word there is could, and it's based on the history of what we've talked about and what we've gone through. But really, when I walk in the door, and 99% of the time it happens like this, they take it. And they say my guys, they take it wherever they take it. There's certain things, yes, you've got to cover. I think from a social work framework, we look at the no harm. We don't want to add harm to somebody's life. So if they are expressing things like suicide, I want to try and empower them to make decisions on about what that looks like. I mean, there's certain parts where we do have the duty of care. And if we're really concerned about someone, yeah, we make the call, but we do it with them if we can. Or we inform them that we're going to do it. We don't just assume, we actually inform them. We keep them in the loop and say, look, I know you said you didn't want me to call 000, but I have to from a duty of care perspective because I want to keep you safe. And it does suck. It sucks having to do that. But if we make that the process and not the exception, if we make it the everyday thing, but not the exception, I think that's where we get ourselves into trouble. It's more of an exception to the rule. And I'm not saying that I'm the best therapist in the world. There's clients that come to me and they do one session like, oh, I'm not going back. And that's fine. Like, that's actually good that you don't just keep showing up to a therapist just because they're a therapist. You actually need to have that rapport with them. But every now and then, yes, we do need to pass them on to someone who is better suited for them. That's okay as well. A good practitioner will help you find the right practitioner. And I do that because I'm not an expert in everything.
I've seen both sides of that situation, psychologists and other practitioners who are willing to admit when something isn't in their area of expertise and help you find a different practitioner. I've also seen people openly accept clients who have presenting issues that are not within their area of expertise or which their framework is not particularly suited to treating. I even had somebody admit to it once, which is quite scary, but people need to understand just because you have a particular qualification, you're not the sum of all knowledge. And that humility is one part of what makes a good practitioner. Well, Simon, this has been a fantastic discussion. Thank you so much for joining me today for this collaboration.
John, thanks for having me. It's really good to connect and see you again. Love the work that you're doing and the messages you're putting out to the world. It's very important.
And to our audience, thank you for joining us. If you do have concerns about your own well-being, whether it be with regard to your mental health, your physical health, or otherwise, please seek professional advice from a social worker, a coach, a psychologist, or another professional of your choosing. If anyone has any questions or comments for us, please feel free to contact us. We'd love to hear from you. And in the meantime, take care.